Giovanna and everyone from the LACNets for giving me the opportunity to present this morning, and thank you for spending your Saturday with us. So I'm going to go fairly quickly through the presentation because I know we have a tumor board as well, but I'm going to cover gastric, small bowel, and just give you a general overview of neuroendocrine disease. So we know that neuroendocrine tumors is rapidly increasing in terms of compared to all other malignant neoplasms. It's the second most prevalent GI tumor after colon cancer. When we look at survival of NETs versus non-NET GI tumors for patients with localized, regional, or distant disease, patients with NETs still have better 10-year overall survivals compared to other GI tumors. So as I said in the beginning, the incidence of NETs is increasing, and if you look specifically, lung, small intestine, and rectum are really the ones that we see much more increasingly over the last 20 to 30 years. The gastrointestinal NETs make up about 75% of all the NETs. In terms of the biologic behavior, it's very different based on the origin. So small intestine, pancreatic, colon NETs tend to be much more aggressive than appendix and even stomach. So really the biologic behavior in terms of the risk of distant disease is much higher for certain NETs based on where the primary began. And we see this here even in terms of survival. Patients with rectal and appendiceal primaries tend to do better than patients who have pancreatic NETs. So I'm going to go through and cover, I can't cover all of GI, but I'm going to cover gastric and specifically small bowel. Gastric NETs comprise about 7 to 9% of the GI NETs. They arise in the enterochromaffin-like cells, those ECL cells of the stomach, and they're mostly in the fundus in the body. There's really three main types. Type 1, which is the most common, is associated with atrophic gastritis, and these patients have hypergastronemia, so high gastrin levels. Type 2 is about 6%. Those are associated with Zollinger-Ellison syndrome, and these are patients that have gastrinomas, also have high gastrin levels. Type 3 is not associated with high gastrin levels. Now, there's differences between these three types. So type 1 and 2 seem to behave very similarly. They're less aggressive. They're mostly found on endoscopy. These are patients who get routine colonoscopies, or you get an EGD done for other GI symptoms, and then they find a polyp in the stomach, and that's how these are usually diagnosed. Type 1 and 2 tend to be they're multicentric, meaning they're more than one, and they tend to be small. So they range in size from just a few millimeters to about 1.5 centimeters. They rarely present with lymph node metastases or distant metastases. Type 3, on the other hand, is much more aggressive. They tend to be usually one lesion. They tend to be larger in size. They usually tend to involve the full thickness of the stomach. And about 70% of them present with regional disease, meaning lymph node disease, and sometimes distant disease. So very different than type 1 and 2. And we manage them very differently just because of the aggressive nature of them. So type 1 can be endoscopically resected by our GI colleagues. So most of the time, they can be, when they're diagnosed, we wait for the pathology, and the GI doctors can go right back in and resect these. And then we follow them with surveillance scopes, usually every 2 to 3 years. If they increase in size, we can do something called an antrectomy. An antrectomy is where we resect the distal portion of the stomach, which is a stimulus for these cells to become cancer. And when we resect these can be done laparoscopically, and patients can do very well, where you completely have resolution of the neuroendocrine cell hyperplasia. But this is usually reserved for patients where you're managing them conservatively, and then when you scope them, you find the lesions have increased in size. Going back here, type 2, usually we end up resecting these. There's usually a single solitary tumor, but if you're unable to resect them, then sometimes patients are just managed with octreotide as part of their management. Type 3, as I said earlier, tends to be the more aggressive kind, so these are not managed with observation or surveillance or endoscopic resections. These are ones where more formal gastric resections are done. So these are gastrectomies where we remove regional lymph nodes as well, just because we know these are the ones that tend to like to spread to lymph nodes as opposed to the others. Small bowel NETs are very different. So more than 60% of patients will present with non-specific symptoms. So many of you in the audience that do have or had small bowel NETs, these are patients who usually present with either obstructive symptoms, they can bleed, they have non-specific abdominal pain. What's interesting about this is 50% of patients will present with liver metastases at the time of their initial diagnosis. So these tend to be much more aggressive. Their ability to metastasize is not dependent on the size of the primary. So you could have a tumor that's less than 1 centimeter in size, and 15% of patients will still have metastatic disease at presentation. Patients who have tumors that are just 1 to 2 centimeters in size, about 50 to 60% of them will have metastatic disease at their initial diagnosis. So size is not a predictor of a patient having lymph node or metastatic disease to the liver. More than 30% of patients will present with multifocal disease. So this is for surgeons managing patients with small bowel NETs, it is critical that when you're operating on patients, you are looking for additional lesions. You can't just assume the patient has one, because about 30% of patients will have multifocal disease, many, many lesions. I had a patient who had 52 lesions at the time of their initial presentation. So it's critical that you're looking for these even when you're doing these laparoscopically. And also keeping in mind, about 15 to 30% of patients with primary tumors, we don't know where the primary is. So we have patients who present with metastatic disease to the liver, and the small bowel primary isn't found, and this is where our GI colleagues help us with doing endoscopic ultrasounds to look for them. So these are where the double balloon enteroscopies are done to help us localize them. So I'll cover duodenal NETs. These are about 11% of our small bowel NETs. They're usually found on screening. Most are usually found in the first and second portion of the duodenum, and 20% in the ampullary lesion. And the periampullary ones tend to be a little bit more aggressive. Most are very single, and they're limited to the superficial portion of the duodenum. And these are managed most of the time endoscopically. So tumors that are 1 to 2 centimeters in size, we do endoscopic ultrasounds to make sure there's no lymph node disease present, and these can be resected by our GI colleagues endoscopically. You don't have to go through major surgery. Very different than patients who have small bowel disease in the jejunum and ileum, where you do have to do a major surgical resection. Tumors that are more than 2 centimeters tend to be much more aggressive, and these are ones where we do talk about doing bigger surgery, and these can be small resections or sometimes involve actually doing a Whipple procedure to remove them. Now, when I talk about extensive surgery, this is the small bowel, the duodenum, jejunum, ileum. How is it that one of them, the duodenum, you can get away with just doing a local resection, and the other two you actually have to do something much more major where you have to resect and debulk? And we did look at these. So this was a study we did looking at over 3,700 patients, where the patients who had duodenal primaries were just treated locally, whereas the patients who had jejunal and ileal primaries underwent resections or debulkings, and the outcomes were exactly the same. So 10 years later, these patients who had duodenal primaries did actually even better just with local excision than the ileal and jejunal primaries. So the duodenal primaries can be treated very easily with just small surgeries, not the bigger resections that we talk about. Even when we look at 10-year disease-specific survival, they still do better. So local excision is definitely an option for patients who are found early that have duodenal primaries as opposed to ileal and jejunal. For nodal dissections for small bowel NETs, for the duodenal ones, or duodenal ones, lymphadenectomy is not required, and that's why you can do these endoscopically. You don't have to remove lymph nodes. You can't do that endoscopically. But for the jejunal and ileal ones, you do have to sample lymph nodes, so removing regional lymph nodes is critical. And we looked at whether the extent of lymph nodes removed or analyzing more lymph nodes helps improve survival, and we did see that. So here in the top corner there, the duodenal primaries, it made no difference at all whether you remove lymph nodes or not. But when you do remove lymph nodes in small bowel and jejunal primaries, you do see a difference. And even if the lymph nodes are negative, the more lymph nodes you actually remove, the better, the longer the patients live. So that's if the top graph there, it's patients who had nodes that were negative. The patients who had more than 12 lymph nodes removed actually lived longer than patients who had 0 lymph nodes removed. So regional lymph nodes at the time of doing the small bowel resection is critical to look at. So in terms of jejunal and ileal NET, surgical resection and removing the lymph nodes around the segment is critical. It is important that you palpate the entire bowel, looking for the multifocal disease, and doing prophylactic cholecystectomies if you're anticipating treating patients with sandostatin after. So how do we do these surgeries? Where you can do these laparoscopically or open. We do open surgery if we know we're going to be doing extensive debulking, if there's a lot of disease involving the mesentery and it's hard to do it through smaller incisions, or sometimes when you're doing this in combination with doing liver resections as well, that's when we talk about doing open surgery. And laparoscopic is safe. Patients are in the hospital for a much shorter period of time, less pain medication, and it is oncologically safe more than anything besides the safety of the operation. So how do we do these laparoscopically? We can run the entire small intestine laparoscopically. This is a segment down below where you can see the black ink. That was actually a double balloon enteroscopy where the GI doctor actually tattooed the area where the small bowel lesion was because it was not seen on any other imaging. So it at least helps us know exactly where the primary can be if they're very small. Through small incisions, we can actually eviscerate the entire small intestine and palpate them. So yes, you can run the bowel, but it's critical when you're doing small bowel surgery to look for multiple nodules. And you can only tell that by feeling the bowel. So through those small incisions, you can actually bring the entire bowel out and palpate it and then put it right back in. And if you can see in the 2 segments below, that's how small some of these lesions can be, and it's critical to look for more than one of them. So what about liver metastases? So it is an important predictor of worse prognosis and survival, especially with small bowel, and there are studies that have shown a 5-year survival of at least 85% in smaller studies. But only about 20% of patients will present with resectable liver disease. And usually when we decide to do that, our disease was confined to a single lobe and also a limited number of disease. We actually looked at our outcomes here at Cedars just recently and looked at whether even resecting just the primary, so if someone presents with very advanced disease, is there some role in at least resecting the primary cancer as opposed to leaving it behind? So we compared patients who underwent resection of just the primary alone, resection of the primary and some liver disease, which was left behind, and then some patients who underwent complete resection of all their disease, and we looked at their outcomes. So we had 301 patients, of which 111 underwent surgery, and about 45% had no resection. And no resection means that just their small bowel disease was resected, but nothing was done to their liver disease because it was too extensive. Some underwent partial resection. Partial means the small bowel was resected, but some of the liver disease was resected, the rest was left behind. And others who underwent complete resection, meaning the entire small bowel was resected, plus all the liver disease was resected at the same time. So we tried to render these patients completely NED. And as you can see, most of these were in the ileum as the primary. The average size of the tumors was about the same in all groups. Number of positive nodes was about the same. They had similar number of liver lesions that were seen, but if you look at the group that underwent complete resection, they did have a lower number of tumors than in the group that ended up having no resection done. When we looked at operative outcomes, most of these were done open, and a majority of these patients had wedge resections done. A lot of the patients who underwent no resection or partial resection had other treatments done as post-operatively, obviously because there was no surgery or some of the lesions were left behind. And when we looked at the outcomes, even for patients who underwent no resection, their outcomes were significantly improved if at least the small bowel was resected. So even though we were leaving disease behind in the liver, their outcomes were great. At 5 years, 79% of patients were alive who had not had their liver disease resected but were treated postoperatively. And those who underwent complete resection, 100% were alive at 5 years. So management of small bowel NETs, just to summarize, can be managed with either bowel resections or endoscopic resections. And if you can resect these patients to R0, meaning that you leave no disease behind, it's important if you can do that. And if you have any disease left behind, to treat them with other modalities, which Dr. Lipschitz will address very shortly. Just in conclusion, it's important. Surgery remains the only potential curative option for patients who have localized disease. Prophylactic cholecystectomies are done if you're going to anticipate treating somebody with sandostatin postoperatively. It's important for all of us as surgeons to make sure that we are looking for additional disease when we are doing these surgeries and not just assume that somebody just has one cancer. An aggressive surgical approach to patients with liver disease. It's important, once again, to emphasize, if you want to seek second opinions, you should. There are a lot of centers around. You want to make sure you're being managed by a multidisciplinary team where everyone's in a room together, making a decision on what's the right thing. Should we do this? Should we do surgery first? Should we do this laparoscopically? Should we do this open? How do we address the liver disease, whether it's surgery or are we going to leave it to our intervention radiology colleagues after that to do targeted treatment? And then important to discuss also clinical trials, PRRT, and when are our patients candidates for this? And I will end there. Thank you so much once again.